1.
This is Unit 1. Go ahead.
Unit 1, respond to 102 South Main Street for an unknown age male. Gunshot wound.
Unit 1 clear. County, do we know if the scene has been secured?
Police are on scene and advise the scene is secure.
Copy that. You can show Unit 1 responding.
Unit 1 responding.
I'll begin by taking body substance isolation precautions and ensuring the scene is safe to enter. According to dispatch, police have apprehended the shooter and they have advised us that we are clear to proceed. The mechanism of injury is reported to be a gunshot wound. Are there any other patients?
No.
We have a number of additional resources on scene, and a Level 1 trauma center is only 10 miles from our location. However, it would be prudent to consider asking dispatch to send an advanced life support unit. County from Unit 1.
Unit 1.
County, what's the ETA on the closest available ALS unit?
A unit is 30 minutes from your location. Do you want them to respond?
Negative, County. Under the circumstances, I believe we have adequate resources. Because this is a trauma patient, I will immediately take manual stabilization of the cervical spine and then relinquish this task to another rescuer.
You're relieved.
Informing my general impression when we first approached the scene, I observed that the patient is supine and motionless. And on closer inspection, I hear a sucking noise coming from the chest, so I'll quickly expose the torso. There is an open chest wound on the right side of the chest, and because this is an immediate life threat, I'll instruct my partner to apply a gloved hand to the wound. Next, I'll assess the patient's mental status. Sir, can you hear me? No response. So next, I'll apply painful stimuli. There are a number of ways to do this. You can perform a sternal rub, but given the close proximity to the gunshot wound, I'll use another technique instead. I could pinch the patient's earlobe, or I could apply pressure onto one of the patient's fingernails about 5 millimeters distal to the cuticle, like so.
The patient moans.
The patient is responsive to painful stimuli. Next, I'll check the patient's airway to assure it's both clear and patent. So, performing a jaw thrust, I'll quickly check the mouth for foreign objects and assess the patient's breathing. The airway is patent, however, the patient's respirations are rapid and shallow, which indicates that breathing is inadequate. So I'll have another rescuer assist the patient's breathing using a bag valve mask attached to oxygen at 15 liters per minute. I'll also take this opportunity to seal the open chest wound using an occlusive dressing taped on 3 sides. Next, I'll auscultate lung sounds. The lungs are clear but diminished on the right side. This suggests a pneumothorax. I'll assess circulation by checking for the presence of a radial pulse. The pulse is present and regular, but weak and rapid. The patient's skin is pale, cool, and clammy. And while there doesn't appear to be any major bleeding, the patient does have signs of hypoperfusion. So we need to treat for shock immediately. The treatment for shock includes high-flow oxygen, proper positioning, efforts to prevent heat loss, and rapid transport. Now, in most cases of shock, I would elevate the patient's legs 8 to 12 inches. However, as this patient is unconscious and has penetrating trauma to the torso, I cannot rule out the possibility of spinal injury. Therefore, elevating the legs is contraindicated. Instead, I'll simply keep the patient in the supine position. This is a high priority patient, so we need to transport as soon as possible. And before we secure the patient to a long backboard, I need to perform a rapid body scan to ensure that no other immediate life threats are present. The rapid body scan should last no more than 90 seconds, and as I assess each body part, I'll be looking for decap BLS, which stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. So, beginning at the head, I'll quickly palpate the scalp and inspect my gloves for blood. Then, I'll check the neck for deformities of the cervical spine, jugular venous distension, subcutaneous emphysema, and tracheal deviation.
The trachea is deviated to the left.
Immediately following the assessment of the neck, I'll have another rescuer apply a cervical collar. Then I'll palpate the clavicles and the shoulders, down the sternum, and along the sides of the rib cage. Do I note any subcutaneous emphysema, paradoxical motion, or unequal chest rise?
You note unequal chest rise.
Moving to the abdomen, I'll quickly palpate all 4 quadrants, checking for distension and rigidity. Then I will very carefully assess the stability of the pelvis, pressing inward and downward. I'll check for the presence of a priapism, and then I'll palpate each of the legs. Again, looking for decap BLS. I'll check for a distal pulse. Then to assess sensory and motor function, I'll apply painful stimuli. Does the patient respond?
Yes, he moans and pulls away.
So motor, sensory, and circulatory function are intact in this leg. Next, we'll perform the same assessment on the other side. Assessing the distal pulse and applying painful stimuli to assess motor and sensory function. Then I'll move on to the upper extremities, palpating down the arm, checking the radial pulse, and again applying painful stimuli to assess sensory and motor function. Does the patient respond?
Yes, he moans and pulls away.
I'll perform the same exam on the other arm, palpating downward for decap BLS, checking the radial pulse, and once again applying painful stimuli to assess for motor and sensory function. Finally, just before loading the patient into the ambulance, I'll raise his left arm. And when the rescuer stabilizing the patient's cervical spine counts to 3, we'll perform a log roll maneuver. So 1, 2, and 3. While the patient is on his side, I'll quickly assess his back, buttocks, and the posterior of each leg. Are there any injuries such as an exit wound?
No.
Also, while I have the patient in this position, I'll auscultate posterior lung sounds. And finally, again on the headman's count, my team and I will carefully roll and secure the patient onto a long backboard. 1, 2, and 3. Then, without further delay, we'll load the patient into the ambulance and initiate rapid transport to the hospital. Because the patient is unable to communicate with me, I'll begin the secondary survey by recording baseline vital signs, starting with capillary refill. Capillary refill is greater than 4 seconds. Next, I'll assess the radial pulse. The pulse is 120, weak and regular. As for the patient's respiratory rate, it's assisted at 16 breaths per minute by bag valve mask. What's the patient's blood glucose level?
84.
Next, I'll auscultate the patient's lung sounds. The lungs continue to be clear on the left and diminished on the right. What's the patient's pulse oximetry reading?
96%.
Next, I'll assess the patient's blood pressure. The blood pressure is 110/94. Next, I'll assess the patient's eyes. Pupils are equal and reactive, but sluggish. How are the patient's skin color, temperature, and condition?
Pale, cool, and clammy.
If the patient were conscious, I would next gather sample history. SAMPLE stands for signs and symptoms, allergies, medications, past medical history, last oral intake, and the events leading up to the patient's injury. However, the patient is unconscious and there were no friends or family members at the scene who could have answered questions about the patient's medical history. Taken with the fact that no medical alert jewelry was found on the patient during the rapid body scan, I won't be able to ascertain the patient's medical history at this time. Next, I'll move on to the full body scan. Now, the difference between the full body scan and the rapid body scan is that the full scan is more methodical, requiring more time and closer attention to detail. For example, while assessing the patient's head and face, I'll pay particular attention to the mouth, nose, eyes, and ears. And as I examine the patient from head to toe, I'll be on the lookout for any secondary injuries which might not have been discovered during the rapid exam. Once again, I'll begin at the head, checking the scalp, looking for blood on my gloves. I'll assess the eyes, the nares, the mouth. I'll assess the ears for the presence of drainage, which might be blood or cerebrospinal fluid. I'll move on to the neck and assess for the presence of jugular venous distension, subcutaneous emphysema, and tracheal deviation. I'll palpate the clavicles, palpate down the sternum, and down the sides of the rib cage, being very careful of the areas just adjacent to the injury. I'll palpate all four quadrants of the abdomen. I'll assess the pelvis, check for the presence of a priapism, and then I'll palpate down the leg. I'll assess motor, sensory, and circulatory function. Then I'll move on to the other leg and assess motor, sensory, and circulatory function. I'll palpate down the arm and assess motor, sensory, and circulatory function. Then, working down the other arm, I will again assess motor, sensory, and circulatory function. Because the patient is secured to a backboard, I won't be able to assess his posterior. This is one reason why it's important to examine the patient's back prior to spinal immobilization. Now, obviously my patient is unstable. Therefore, I'll reassess his condition every 5 minutes en route to the receiving hospital. I'll repeat the primary survey, assessing the patient's level of consciousness, his airway, breathing, and circulation. I'll perform a focused examination of the patient's injuries, in this case, the gunshot wound to the chest, and I'll evaluate my treatments and interventions. After that, I'll reassess vital signs, paying particular attention to signs of a developing tension pneumothorax. And if time allows, I'll consider treating any minor or secondary injuries that were found earlier during the physical exam. I'll conclude by giving a radio report to the receiving hospital, briefly describing the patient's condition, the interventions that have been performed, and how the patient has responded to the treatment.